Good afternoon, colleagues, and thank you for connecting us on this webinar. Perhaps then I should just start with a few announcements. Firstly, we had Professor Kawe, who was going to host the meeting for us, who has got some tragedies in her personal space, COVID tragedies, one very sick and one death just within the week. So she's not in good emotional space to do what she was going to do. So you'll be under my spell for the next hour or two, and I'll do the best to coordinate. I would need somebody, because this is what I would do then. I would need somebody who would stand by to watch the chats on the side, and I'm uncertain how to decide that right now. But we will figure it as we go, unless somebody offers themselves, and then they can just support me in making sure that you keep an eye on the questions that come through in the chat room. But otherwise, then I'm going to introduce to you the panelists that we have and the manner in which we're going to run the proceedings. Most of you must have captured already what it is about. Every epidemic puts an acid test on health systems and puts pressure for it to deliver in the immediate. And so this is what it has done, the COVID-19 pandemic has done to us, and we want to respond to that, even if belated in some respects. We want to use a rear view mirror to then see how we can close the gaps that some of which are very glaring, that we can see, and improve as we go our response to the pandemic. So, and then secondly, we in particular want to highlight the fact that every epidemic puts pressure on the health system, both to test and to incite or inspire or pressurize it towards improving its collaborations. Collaborations are called on across all various spectra, and integration of healthcare delivery. And the essence of this webinar then is to look at how we are coping with collaboration and integration within the region ORT district, but we're going to use that lens also to examine what's happening across the Eastern Cape from our collective observation as we are in this province. Especially, I would think that those who are not in this province have been picking up our news, us on the news, and would be wondering what is veracity and what is to be sifted in what they get in the media. So we hope this is going to help to shed light on the actual realities on the ground. They might be more shocking than what you picked up in the media, but we're going to give our best. But then we want to get some collective wisdom in terms of enhancing collaborations. A very specific focus, and again, one announcement I need to make is that our district manager is not on, and I hope if she is, she could just notify me so that I recognize her. I haven't seen her on the list of attendees. She and I and a few others have been looking at how we can take the responsiveness to the pandemic right down to the community, or should I say, right down from the family through community level 1 care and all the way to tertiary. The national response when we started off was a knee-jerk response of getting excited about ICUs just because of the drama of the respiratory distress and death that is inflicted by the virus, without looking at the fact that we need to stem the tide from where it starts. And so therefore we're waking up to that now in a vigilant manner, and we're trying to do that in supporting the public health the best we know how. And we are integrating into that the conversation about what the role of the GPs in particular could be in enhancing level 1 care that goes down right down to the family. And the GPs that will be joining us here will be coming in to share a lot of their views in terms of how they could play a role in making sure that the health system gets tightened in terms of responding to the epidemic. And the second element then is private health in terms of hospitals, how they could also come in and play a significant role in well-crafted and structured linkage with the system in collaboration and integration of care. Then we've got 4 inputs, panelists that are going to be speaking to us on these. And Professor Hera is the head of the School of Public Health at the Walter Sisulu University in Umtata, and is going to take us through both theory and practice in terms of integrated response to epidemics. And I'll give him that opportunity now, and I'll just introduce every panelist as they come in. So over to you, Prof. Hera. I think you can then come through and give us your mic and give us your face, please. I trust that Francis has assisted you with the slides, Prof. Or are you going to play them from yourself? Have you been assisted with the slides?
Are you not going to play them?
Okay, all right then, Prof. Maybe you could then, in the meantime, just be introducing yourself while I greeting the audience. While I'm just doing that very quickly, I'm going to share my screen for you.
Okay, it's fine.
Thanks.
My name is Francis Sierra. I work with the Walter Sisulu University, the head of Department Public Health. I'm the entrusted person for the Walter Sisulu University in terms of COVID-19 prevention, and also working with the ORT district in terms of advisory for the COVID-19 response outbreak. So I'll be taking you through few slides, but all of them are actually focusing much more on OR Tambo district. So if you see most of the information is from OR Tambo, please don't be surprised, because I didn't want to go much more at an international level. I wanted to do it international level, but when I saw it is OR Tambo, then I had to focus on OR Tambo. So here comes ORT, private-public collaboration in response to COVID-19 pandemic, principles in public health emergencies. Next. Public health mission and health systems. Mission of public health in emergencies is to assess and monitor health of communities and population at risk to health problems. And this is actually the core of public health. Second, to assist in formulation and design and addressing the identified problems. Third is to advocate for broad access to appropriate health promotion, disease prevention and evaluation, which is also a core component in terms of what we need to do for designing and also making sure that whatever we do is much more evidence-based. If you can see this, cycle here, you see at the center here is actually we have research. And this research is actually for evidence-based, what we need to do so that we get an information which is much more accurate. Next. Next, okay. This is actually an overview of how OR Tambo is, how the whole district province is in terms of the cases. You will see that most of the cases are actually at Nelson Mandela Metro, followed by Buffalo City, and then OR Tambo, which is our focus district, is actually the third in terms of case numbers. Next. Can you narrow a bit your screen? Okay. Summary of statistics. Thank you. Summary of statistics and hotspot mapping of COVID-19 cases, recoveries, and deaths in OR Tambo district as of 17th July. The total population of OR Tambo is 1.5 million. Cases which has been screened is 257,918. Total tested, 32,860. And the recoveries out of all is actually we had 7,423, and death, unfortunately, we lost 145 cases. And out of this, by now, we have active cases about 1,983, which is approximately 2,000. Next. So OR Tambo Private-Public Initiative, which is ORT PPI, making sure that no one is left behind. Our aim is actually to make sure that all parties come on the table in terms of this, the contribution for the COVID-19 prevention, COVID-19 treatment, and COVID-19 war that is being currently fought in. So our Tambo ward-based teams model is similar to Masipasane approach, where all stakeholders form part of this approach. This approach is not limited all to the underlisted. Political leaders, which includes local councillors, ward committees, co-health team with named leader and all categories, such as public nurses, EN, environmental nurses, community health workers, and health professionals. Doctors working in communities, including specialist family physicians, epidemiologists, and emergency physicians and internists. NPOs, NGOs, and private health facilities, including GPs and specialists, community leaders, traditional leaders, and chiefs. Union representatives, associations, religious leaders, youth leaders, school governing bodies, and other leaders, including those who are actually within the streets. They need to be co-opted in terms of this war. Thank you. Next. So components of an effective emergency response team. The key is actually planning. If we don't have a proper plan, you cannot have a proper system for controlling this emergency. So here we have being prepared for critical incidents involves 4 important components, which is planning, reviewing, transport, and testing. These are the cornerstones of emergency response plan, and it should not be noted that it is in a circular rather than in a linear format. As you can see on the right hand, actually this shows how emergency management can be done. So these processes are defining an emergency and planning team. When you are planning an emergency planning team, you also need to put up an implementation plan, which is very vital. Establishing teams with specific tasks to function immediately before, during, and after an emergency. Like in OR Tambo now, they've developed war rooms and data management teams and clinical management teams, which are actually in the forefront in terms of this combating this pandemic. Establishing a method of utilizing resources and for obtaining additional resources. Currently, we have to work in terms of what we have at hand. And defining means of moving from normal operations into and out of the emergency. Next. Planning in the key. Coordination is actually a crucial, important part. These are not limited to the underlisted. Resources, both human capital, tracers and testers, and equipment. Test kits, equipped ambulance, oxygen supply, which is much more critical for those who have been affected and who are in critical condition, especially in our ICUs. Training capacity building and availability of data collection tools, standard operating procedures and policy documents. Continuous risk assessment and contingency plans should be put in place, such as surveillance plans, which are very vital in terms of monitoring the pandemic as such. Media plays a very big role, and advocacy, communication, and social mobilization, which has a bit, in terms of communication, been a bit of a gap in terms of all what we are doing currently. Handling COVID-19 patients, their families, and employers. Reintegration back into the community after treatment, which has been our biggest backlog, actually, or biggest gap that we have been not able to fight this war with our communities. Some outside groups or agencies that could be considered at this stage in the planning process include local police department, emergency medical services, city office, emergency management, local emergency planning teams or committees, public works, telecom companies, NPOs, NGOs, essential contractors, suppliers of emergency supply, and trade unions, which are supposed to be included. Next. Okay. Public health emergency preparedness and response capabilities in terms of planning model. This is just a planning model. We have 1, assess current state. 2, determine strategies and activities. And 3, develop plans. So under assess current state, we have assess organizational roles and responsibilities, assess resource elements, and assess performance of these what we have currently. Second, determine strategies and activities. We have to identify and review jurisdictional inputs, prioritize domain and capabilities, develop short and long-term goals. And other developing plans, we have to put a plan, organizational initiatives, plan capacity building activities, and plan, plan capacity evaluation demonstrations. Next. Next. No, backwards. Backward. Yes. Early warning and response. Early warning response. Data is vital to make informed decisions. Here we have ability to detect and respond to outbreaks. We have 5 steps of emergency response framework. Collection of information, identification of signals, event verification, and monitoring of public. The 5th one is not seen. Can you go down a bit? Hello, can you go down a bit? Yeah, the 5th one is actually mounting and public health response plus communication. Next. Next. Yes. So this is actually the event IHR, International Regulation Event Notification and Determination. This is very important when you are dealing with any emergency within any place, which is, if we see here, action, decision, status, and source. If you see the blue color, is actually, in most cases, it is supposed to be in here. The colors are missing. Hello? Well,
we can hear you, Prof.
I said the colors are missing. They have colors on all this, and it's fine. But in most cases, It's fine, no problem. In most cases, most of the incidences actually start bottom up. So we were supposed to get information from the private, public, clinicians, community concern, media, public services, which actually refer the information to the hotline or informal system, event-based. And then on the other side, we have healthcare system and laboratory and pharmacies, which are all in blue. Then they go to the surveillance health system, event-based. And from there, they go to unusual disease, which is a pattern, event verified. And then they go to signal. And this signal actually is supposed to be red, because it's from the signal where we will be able to act. Then from that point, yes, now it's fine. You see the signal is red. Then from the signal, we go to the public health significance. And then if it's yes, then we go to alert, health risk identified, and then investigation and control as an action. And finally, we go to international level, international health concern. From international health concern, we go to status, which is public health event of international concern. And finally, you report the case to notification to WHO. However, in this pandemic, the reverse has happened. It's not as it's supposed to be on this chart here. We started getting the information from WHO and other international organizations. And that one actually created much more panic to most of us, to an extent that the community was actually the last to be informed, instead of the community feeding the information to the rest of the system. Next. Next. Next.
Thank you, Patrick.
Okay. Challenges. We have the spread of COVID-19 is growing fast. No? Oh, wow. Okay. Resources and infrastructure are not enough for effective truncate to spread and provide care. Human behaviors and adherence to lockdown measures. And finally, health personnel are also infected. Next. Next. Okay, lockdown gaps on COVID-19. I would like to put up these events which have not actually been done. We were supposed to have a pre-lockdown preparations. Unfortunately, there was unclear goals and strategies on COVID-19 and its impact to the communities. The communities were not aware on what is happening. Maybe during the question and answers, I will be able to elaborate on this. It created more fear, phobia, and panic to communities instead of the awareness information. Lockdown goals and implementation were quite clear. It was a reduction of diseases, transmission rate between person to person, cut the chain of transmission of viral multiplication, buy time for the virus multiplication, and reduce pressure to the health system to cope with the current situation. And finally, we also need to put up the post-lockdown plans and strategies. This includes counseling, readiness for future, any type of emergency, integration and collaboration of PPEs, plus preparation of communities at all levels. Under counseling, actually, psychology also goes with this word counseling here. Next. Next. In conclusion, public health is a large field of multiple disciplines which requires collaboration and strong coordination across sectors and other agencies. Validated information is crucial to make most informed decisions. Public health team in emergencies is always evaluating the needs of vulnerable communities, deciding on effective health response, providing recovery to plants and populations and health system, provide technical support to prevent measures, health promotion, community involvement, and advocate for winning strategies, assist with implementation and evaluation of interventions. Thank you very much. These are all that are prepared and waiting for your comments and responses. Thank you.
Thank you very much, Prof. We thought that for managing time, we'll ask the audience to keep their questions until right at the end of the presentations. So you'll stand by and keep looking at the chats and picking up questions that you think are relevant to your presentation so that you prepare for when we get to the sessions on questions and answers. But there's one that stood out, which I just want to highlight, which is a question of, which is a comment that says, excellent, brilliant, succinct presentation of theory. What has been the practice, and why does there seem to be a failure or very poor success on the theories that you present? But that'll come in later. And I think a second critical one was psychological support to everybody. You alluded to it a little bit, but again, I think we've got experience that we can share during your time of response. So then, colleagues, I'll invite Dr. Mark Human now to come in and give us his presentation. And Mark, you may again just take a bite a little bit in introducing yourself beyond what I am presenting here in terms of your responsibilities at the Medical Association, Orthopedic Society, and everything else that brings you here. Thank you very much for what you have done on behalf of SAMA in terms of public-private collaborations, conversations, and we look forward to your presentation. Thanks, Mark, your time.
Thank you very much, Cecilia. It's much appreciated. And thank you very much to all the participants for joining us on a Sunday afternoon and sacrificing your leisure and family time. I'm going to go straight to my presentation, but just to give you a little bit of background on me, I'm an orthopedic surgeon in private practice. I chair the Gauteng branch of SAMA, and I chair the Human Rights Law and Ethics Committee of SAMA. I have been involved mostly in the private sector, and in trying to bring the private sector, somehow get us involved in the battle. Not that we're not involved, but a degree of partnership has been missing. So this is us at SAMA. So we all know where we are at the moment. How bad is it really? The combination of a global pandemic and what we have is a very scarce resource in terms of finances, in terms of human resource, in terms of equipment, beds, the whole lot. Take these two things together, and it's not long at all before you're going to have a completely overrun healthcare system. We've seen this in the Northern Hemisphere in countries far more well-resourced than we are. And these are the kind of scenes that we've been seeing. Mass treatment facilities put together, these are before they went into use, and that was Spain and Italy. And then China, beds full everywhere, New York, tented camps, and ultimately lots of this, which is what we really don't want to be seeing, mass graves and so on. So this is us. We're the healthcare workers. And what we have to try and do is get the message out and implement a strategy that results in this: leave no man behind. It's the analogy to a wartime situation has been made many times, and I don't think there can be a better analogy. There's been a lot of planning going on in the background, but it is somewhat disappointing that 5 months ago, the World Health Organization published this in their strategic planning document. And I'm just going to read it because it's very important. Inadequate or under-coordinated preparedness of interdependent public and private organizations will reduce the ability of the health sector to control the spread of disease. it's almost self-evident, but somehow we still don't, that message still hasn't sunk in fully here. National authorities, with the support of partners where requested, should designate referral facilities for care of patients with 2019 novel coronavirus and map existing public and private health facilities, map them, and referral systems in case they need to be brought into the response as surge capacity. So what's the extent of our problem in South Africa? This is a very busy slide, and already some of these numbers have changed. Hospital beds have probably swelled by about 20,000 with some of the mass treatment facilities and opening of wards. So we're probably closer to 130,000 hospital beds. That's still a very small number of hospital beds for 60 million people. In terms of doctors, our health professionals Society, HPCSA, has 48,000 registered doctors, but it's commonly held that about 10,000 of those are overseas. In truth, there are no accurate statistics. The most recent things you'll find if you do some studies are from about 2014. We estimate that there's somewhere between 35 and 40,000 doctors, and they are structured the way that you see them there, with about somewhere between 55 and 60% of the doctors in the public sector, and somewhere between 35 and 40% of the doctors in the, 40 and 45% in the private sector. Specialists, you can see there's a slight predominance in the private sector, and GPs slightly the other way around. Nurses, and this may be something that we haven't really placed enough emphasis on. South African Nursing Council says that they have about 285,000 registered nurses, but if you add up all our nurses that we're aware of working in the public and private sector, we're missing over a third of our nursing population. And it's a very good question. Where did they go? Have they all gone overseas? Have they retired? What's exactly happened to our nurses? They are more essential to the fight even than we are as doctors. The disappointing thing is that when you put these numbers in context of our population, South Africa has 0.7 doctors or thereabouts for every 1,000 members of population. To compare us with the Northern Hemisphere European and the first world countries who are up in between 3 and 5 is silly, but even comparing us with the sort of G20 type countries and the BRICS countries, their average is around 2. At 0.7, we have a severe shortage of doctors. Our nurse situation is not that dissimilar. It's in South Africa, it's about 3 per 1,000, whereas a lot of these countries are well over 10. So we have severe resource constraints, as you've just heard. We have geographic and logistical and economic constraints that make self-isolation in South Africa almost an impossibility. And we have a shortage of quarantine facilities. We have a shortage of hospital beds. And in particular, you've heard high acuity and ICU beds. We have a shortage of human resources, and that's really our biggest shortage. So we've heard people talking a lot about we've heard them talking a lot about ventilators and about ICU beds, but actually if you don't have people to staff those, then we have a problem. We have a shortage in equipment, and that's the ventilators and so on, high flow nasal cannulae. There seems to be some sound interference. I don't know if we can just check, Patrick, and mute someone's microphone. Thank you. And of course, equipment also comes with PPE and drugs. And there's been a lot of talk about PPE, although I think we have made considerable progress in that regard in the last 4 months. So how do we integrate the sectors? Strategically, you can divide the phases of this disease, and we did a huge amount of epidemiological and preventive type planning. Actually, I think we spent way too much time and effort in that department, and we did not get to the point where we thought, what are we going to do when people start to get sick and treat them? So I think we were rather late as a nation coming to that party. We have a pre-hospital environment, and it was always envisaged that the GPs really would get very involved, but across the board, that has not been the case necessarily. These partnerships are growing. there was a mooting of GP type clinics or fever tents, places where GPs could see patients who were sick and suspected to be COVID, but outside their own practices, so thereby diminishing the risk of acquiring or transmitting the disease to other patients, because we mustn't forget that we still have all the other patients, and to staff members. Tracking, tracing, and isolating of contacts. We spent a lot of time on this as a nation, but one of our biggest failing points was the fact that the minute a test stretches out, a test result stretches out to more than 48 hours, it is absolutely impossible to trace the contacts. At 72 hours, if you take someone who spent 30 minutes in a taxi with 16 other people, and then those 16 other people did the same the next day and the next day, we have well over 4,000 contacts out at the 72-hour mark. So we lost control of this very quickly, and we should have abandoned and changed our testing strategy and focused far more on the hospital environment very early on, and maybe done random screening tests to try and pick up asymptomatic cases in the population. The function of ward-based outreach teams, really, I'm not sure that it's been properly utilized here. In hospital environment, obviously we have the state sector and the public sector. It was always anticipated, the state sector and the private sector was always anticipated that the state sector might fill up first, and having a relative deficiency of ICU beds, that it would be needed to move patients from the state sector into the private sector because of the relative excess or higher numbers per ratio of high acuity beds in the private sector. So it was always thought that the patients would be moving, but that really has not happened as much as we thought it would. Moving resources to the patients, this is a very, very valid point. You know, we have a functioning military, and this is something that a functioning military should have as one of their capacities, is to be able to send doctors equipment and set up tents and set up ICUs and these kind of things, especially in rural type environments. Why is it that only now, 5 months down the line and 4 months from when it really started here in South Africa, are we starting to now see the military intervention? That's been a little bit slow in coming. And then post-hospital, I don't know that we've paid enough attention to this. We've seen how the UK made a huge blunder when they started sending patients home who had allegedly recovered or were well enough to go home, especially into retirement villages and frail care centers, and then infected all the people there, and they had multiple deaths in this regard. So one of the ways that you can take care of this is if you're able to discharge people slightly earlier than they would normally go home. And if you can provide things like a saturation monitor or a ward-based outreach team with GP supervision, then you can get people out of hospital earlier. And that's probably the best place for our field hospitals to come in. That's probably the best place for them to be utilized. Of course, getting all this together, and please, apologies for people who've seen that already, but that really is what it's like trying to organize your healthcare initiative, especially when you're trying to do it in a cross-sector or cross-disciplinary way. Fortunately, a lot of our key objectives are already aligned, or at least we hope so. Coordination of this kind of integration between the public sector and the private sector realistically can only be done through the provincial districts of health. Even when the national health policy says X, the provincial districts, the provincial health departments are able to implement Y or sometimes Z. And so sometimes there's a big disconnect in that regard. And at district level, this is even more important, because this is the nuts and bolts of individual hospitals and individual specialists talking to each other and working out where the problem is and how best to treat it. Establishing a two-way dialogue between the public and the private sectors, and between GPs and specialists, so that people can be referred, because that's typically what we expect it to happen. Overflow from one sector into the other, patients who are not well enough to stay at home being needed to be admitted, and normally those would be seen first by the GPs. Unfortunately, we have such a hospice-centric state approach, and it is set to change. But a lot of the patients have been presenting at large hospitals instead of being taken care of in out-of-hospital settings. And then finally, facilitating a means of cooperation between the sectors and between the different disciplines and specialists and GPs. So these are our main 3 objectives. These fall, of course, under the ambit of our main 3 broad principles, which I think these are all things that we all agree to, or that most healthcare workers agree to. We have to be able to, at some point, implement universal access to healthcare. It is not a dream, it is an absolute concrete goal. It's a national requirement. And something like the coronavirus pandemic really has highlighted that. We need to be able to adopt a patient-centered approach. And we need to be able to implement community-level interventions. And this is the one thing that I also think we as a nation have not succeeded well enough in. The 3 hallmarks: social distancing. If you are 5 meters away from someone, they pose you almost no damage, no threat rather. If you are wearing a mask, you're able to get a little bit closer to people before they pose you a threat. If people are washing their hands, it just makes it so much safer. Those 3 things, I think there has been so much fear-mongering and paranoia. The moment a healthcare worker gets sick, they close that department. It does not make any sense, absolutely no sense whatsoever. If we did that across the board, we would not have a healthcare sector able to render any care. This is not a 100% fatal viral hemorrhagic flu. Yes, it is a lot more dangerous than ordinary flu, maybe 4 or 5 times, I'm not sure. But at the end of the day, I think the paranoia has overrun this a little bit, and that's down to a failure of education and perhaps a little bit of fear-mongering in the media. And education needs to be not just to the population, but to our healthcare workers in particular, the cleaners and the nurses. We need a way to consolidate our combined national healthcare asset. If 2/3 of our beds and 2/3 of our doctors are in one sector and 1/3 in the other sector, we need to be able to put them together. Otherwise, we have a 2/3 or 1/3 or even less than that chance of succeeding. It's the only way that we will secure and sustain our entire health sector going forward and somehow preserve the access of the patients to healthcare. We mustn't forget that post-pandemic, there is likely to be a very big rush of all the illnesses, all the diseases, all the problems that have not presented as emergencies in the past 4 months. And then there's, of course, an element of social solidarity. People, our general public, need to take some degree of responsibility upon themselves. Without that, we are all dead in the water. And they need to understand that us healthcare workers cannot do this on our own. We are happy to give up our time and our efforts and even put our lives in danger, but we cannot do it on our own. So what progress has been made? A huge amount of activity, and probably the best examples are things like the Volkswagen multi-bed hospital, the Nasrec multi-bed hospital, all the planning that you saw on Prof's slides. A huge amount of planning is going on, but I don't know that there has been enough cross-pollination between the public sector and the private sector. The SAMA encouraged the formation under a bunch of independent practitioner organizations, GP organizations, of the United Forum of Family Practitioners, and they have been engaging with the Department of Health. This is really to do with both pre and post-hospital care. And as far as one of the things that we might have also missed is the integration of our district hospitals, because it seems from a state side of things, we have placed a lot of emphasis on the large tertiary hospitals. Specialist engagement, numerous groups have partnered together. The specialist societies, the South African Private Practitioners Forum, the Progressive Health Forum, and SAMA have all come together to try and engage with the Department of Health and come up with solutions. And that was largely to do with the transfer of patients between the sectors. And of course, there's now facility in some provinces for recruitment into the state facilities. Again, have we left the nurses and the allieds behind? Because I still think that our biggest single rate limiting factor is our nursing force. So what's still missing? What can we still do? Information. It's disappointing that 4 or 5 months later, we don't have a transparent dashboard. This dashboard should be available on a national level, on a provincial level, across private and public sectors. It should not be a separate thing. And a doctor in any environment, in any district, should be able to put in their MP number and log in and work out exactly where the hospital beds are available in their district. Why is this not available? Our disaster management plan is 17 years old. Surely when they thought about a disaster, this must have been one of the things that came up. This dashboard, we keep hearing about it. I believe that one was launched in Gauteng in the private sector this week, but we still don't have access to it. Provincial structure, doctor representation. I can't stress this more vividly or more loudly. These planning departments and these COVID command structures are all fair and well, but you need doctors on the ground level representing their organizations, representing their hospitals, not just the hospitals. That's one of the problems that happened. The main representation of the private sector in the governmental sectors has been from the hospital groups, with very little input from the actual doctors themselves. And district hospital integration, we brought this up just a little while ago. Facilitation of an expedited per-cell registration. Most large corporations can load your details and have you on the payroll within a few hours. Why is it that takes weeks on our per-cell system? Especially if we're looking to employ people in an expedited fashion, we should be able to do this in less than a day. And sustainable solutions for private practices. You have probably all read about the Progressive Health Forum framework. In truth, it was a framework put together by a lot of organizations, and the Progressive Health Forum acted as an umbrella. In very simple terms, what it does is it shifts the thinking of the private sector, because our private sector is based on a fee for service, and that means that only once you have delivered the service does the practice get remunerated. In many countries overseas, there are advanced capitation models. So everyone pays their medical insurance. The insurers then pay the service providers, and the service providers deliver the service. They do not get remunerated in arrears. And that's a model that we're looking at to try and preserve. And here is the most important thing: to try and preserve both GP and specialist practices so that they are still there. Because with the usual overheads and running costs, a lot of these are under severe threat of going bankrupt at the moment. People will do what they need to feed their families, be that go into early retirement, be that go overseas, be that whatever they may, look at other alternative situations. We do not need to be losing healthcare workers now. We are going to need them more than ever post-pandemic. So the one thing that this is the obligation that rests on all of our shoulders, how do we produce a unified healthcare asset? And at the end of the day, it comes down to two things. We all need to summon up every ethical bone in our body, and we all need to grab every little bit of responsibility that we can. Take responsibility for the little things that you can control. There's no point in fighting about the big things that we can't control. Take responsibility for these things and make a little bit of a difference. We did not go, any of us, into healthcare to try and get wealthy. We would have become businessmen. We went into healthcare to make a difference. So that's our role now: make a difference. Thank you very much.
Appreciate it, Mark. Thank you very much. Thank you very much. Again, your questions are coming through and they're being pooled so that we can respond to them at the end. I'm going to ask Dr. Adri Kok to then come through and take the platform. She's from the Association of Internal Medicine Specialists, but she sits on the South African Private Practice Forum. She'll do better introduction of herself. She's been working on this for a while now, facilitating and assisting these conversations. And she's bringing that wisdom gleaned from what she has facilitated very strongly in the Western Cape. And I think she updates us even better than I would have if I tried to give a little bit of what's been going on there. But Adri, thank you very much for the work you've done there. I've got it secondhand behind your back, and that it's been a huge labor, and it's still not complete, but it's having traction. And we want to build on that the best that we can. I hope there's going to be enough time after the last speaker. We've eroded into the rest of the time. So I think let me warn Stacey now that she should also just make sure that we do have enough time, because we want to zoom in on the area, on the region where we are, because that's where we want to actually cut the ice. Thank you very much, Adri. Let me hand over to you.
Thank you very much. I won't waste time. So I think it's really important. And can you see my slides?
Thank you very clearly.
Okay. So I think the importance is the scope of this pandemic is absolutely like nothing we've seen before. And there's a clear evidence that this is an international disaster. And I think there were deficiencies in our healthcare system, some of which Mark has alluded to. And Professor also showed us what is ideally envisaged and which has not happened as well as we would have liked, especially the fact that some provinces have not had the response that one would have needed to be ahead of this pandemic. I think the most important thing is that the ICU beds and the ventilator availability is restricted. Personnel, nursing especially, as well as doctors, we don't have the freedom or the luxury of having as many doctors per percentage of the population as our counterparts overseas. At the same time, South Africans we're not really scared to work, and we are prepared to look after our patients. And I think it's important that our discussions with the Department of Health has always been to try and I work in private practice, just to make that clear. I'm a specialist physician. And we've tried from the start, when we saw way back in February already, that this pandemic definitely was not going to miss South Africa, even though we had a slow onset of patients, that we tried to really negotiate and speak to the Department of Health to see if we could find a way where we could coordinate care better. So from the South African Private Practitioners Forum, we also worked with the Progressive Health Forum, as well as with any of the shared groups like the Hospital Association of South Africa, to try and see how best we could support the health services and to get this mechanism going ahead of the surge, not to wait for the surge to happen, but to try and prepare for it. The proposed mechanism of a private-public interaction was then with a service level agreement, which I will call an SLA from now. And this was really to see how we could coordinate better the private hospital groups and doctors to care for state patients. And also understanding that there is a restricted amount of beds available across the country. We don't have the luxury of having too many ICU beds or even hospital beds. And more importantly, you can have a bed, but you've got to have the personnel, especially the nursing personnel, to be able to service that bed. We've had wide consultations. We've tried our best as well from our point of view to speak to the MECs of health of the different provinces and the DG to try and see what mechanisms there are in which this whole SLA could be incorporated, and more importantly, to try and see what would be the best way to treat as many patients as possible. Now, I heard Dr. Humans say that this is not something major in one way, but I must say that I've been on call the weekend, and it is absolutely hectic, and the number of patients that are critically ill that come to hospital in severe distress has been very, very alarming. And I'm in Gauteng, and I think KZN is experiencing also what the Eastern Cape and Gauteng is experiencing. So these are really three big provinces that are going through the surge of patients. And this may carry on for 8 to 10 weeks, depending on how the patients respond. If we look then at this contract or the SLA that was negotiated, it has 5 components. So there's a different one for hospitals, one for doctors, one for radiology, one for pathology, and then for the allied healthcare professionals, or as they should be called, the medical professionals, so physiotherapy and dietitians specifically, but things, people like speech therapists and occupational therapists may also come into that fold. What was really not adequately covered in the SLA was the need for psychological support, palliative care, and the ward patient, where you really have to have ongoing support of that patient. So it's not just the ICU or the critically managed patient that should be attended to. If you look at the number of people that land up in the intensive care unit, you run out of beds very quickly. So our focus has been to try and support patients outside the ICU setting with supplemental oxygen. So essentially you're still in an ICU environment, but you're doing it in a ward space because there's simply not enough ICU beds for us to be able to do it in the normal circumstance. So you would have patients where we have had to resort to high flow oxygen and wall CPAP in the ward situation, as we had to support their ventilation much more aggressively. So all of this had to be brought into the fold when we look at how do we manage these patients. So the ethical considerations, absolutely crucial. So you have to now consider, do you ventilate a person that's maybe 88 or 90 years old versus a person of 40? Do you ventilate them? Who do you choose the ventilator for? What about your clinical guidelines? There are no hard and fast rules as to how these patients should be treated, because unfortunately it's a shifting, it's like a shifting platform. If you look at the results of some of the studies that have come out, they've been disputed. We've really gone on best evidence and also clinical experience as to what works and what patients benefit from. So the clinical guidelines have been really fluid because no specific guideline has ever really been developed. Unlike things like diabetes, hypertension, where we have quite fixed guidelines that show us how to manage those patients, this has really been a situation where we learn as we go along. Nobody's written a textbook about COVID because it's really caught all of us very much unawares. And we've had to look at best experience overseas and really apply that to our patients locally. The clinical governance and medico-legal indemnity is absolutely crucial again. And this all comes into this SLA to ensure that there is a good framework in which you can manage the patient that comes your way. The referral mechanism is important because, again, this has to depend on the bed situation. I did mention on the chat that there is actually a dashboard available. It's mainly done by the hospital joint organizing committees, where they do respond and make sure that people know what beds are available. But this is mainly in the private sector. I'm not sure if the public sector have had the same availability to communicate that data, because this is really crucial to be able to refer patients adequately. Then there's the financial aspects. Now, there's a lot that's been said in the press that all the doctors are interested in is money. I must say that this was very disappointing because this has not been the focus of our discussions. It has all to do with the fact that we've had to ensure that there is equipment available, there are doctors, nurses available, the bed is available, so that when the patient does arrive at a private facility, they can be accommodated adequately. And so the financial aspects, although it was part of the SLA, was definitely not the main focus of the discussion. Issues that arose, the anesthetists were very different in their approach. They wanted to have a different kind of financial model, which the Department of Health wasn't happy with. And so they were very adverse in their approach to the SLA, and have influenced many people not to sign it. And I really hope that people with this presentation today could take the message out that the whole reason for this SLA is to try and really treat as many patients as possible, accommodate whoever, whether they are funded patients or not, and to try and ensure that we really approach this pandemic with all efforts and all hands on deck. The general practitioner involvement, I cannot stress enough. I've seen some notes on the comments where people have said that they've not been involved in the management of patients. I think the general practitioners is absolutely the backbone of the pandemic. And if you look at how our general practitioners have managed patients at home, they've done an absolutely sterling job. What we did right at the start of the pandemic is to send out information to our general practitioners in my area, for example, to give them an idea what to look for, how can they monitor patients, how can they treat them at home, what do the guidelines say, are there any preventative measures, and then if the patients do contract COVID, how they can keep them out of hospital. And we've had daily communications with GPs that have managed patients outside the hospital. And I would really just encourage, if there's any way that the provincial sector can use the general practitioners in their area, that they should be doing that as much as possible, because that can really make a big difference to the volume of people that do come to the hospital eventually. The JOC referral system has not been finalized 100% from the Department of Health point of view, but there have already been some inter-hospital referrals. This is done to ensure that there's not a confusion. The patient has an authorization number, and there's a very clear system in how that patient then gets managed. And there's a security also that the patient gets managed in the public, in the private facility. Then importantly, how do we discharge the patient, and where does the patient go afterwards? The bed and resource availability has been a big issue, and there is a difficulty that patients with EMS availability, EMS has been under the pump with this pandemic because people collapse at home. They've often had to be resuscitated there, and they actually arrive at the hospital with the patient intubated by the time they come to the emergency departments. Patients who can come in time when they see that their situation is worsening, that's made a very big difference in how we could actually manage these patients in the hospital setting and avoid them having to be on a ventilator. Why are doctors reluctant to sign this SLA? There's been uncertainty. Some actually felt they would rather work pro bono rather than have payment. The resource restraints or constraints is absolutely part of the problem, that there's not an innumerable number of beds, and patients have been staying in ICU for 7 to 10 days because it takes that long really to come through the emergency part of this pandemic and the COVID clinical situation. If you then look at the patients that do well quickly, we are able then to discharge them quickly. And what we can do then from a private practice point of view is hand them back to their general practitioners for monitoring, and they can consult with us if there's any questions or any problems that arise. And we've even had the opportunity to have patients on home oxygen, which has been very useful. Medical aid contracts exist, and patients, funded patients, have a contract that they will be seen at a hospital. And again, this has to be borne in mind, but that doesn't mean it excludes a patient from the public sector also having the ability to be in one of those beds. So I think this is really a situation where we can share and make sure that we are able to service as many patients as possible. Our recommendations from a SAPIF and also from the physician's point of view is communication. Talk to one another. The Department of Health, we are there. We would really like to help where we can. We've tried to encourage as many doctors to sign the SLA as possible, and we hope that this has really shown a willingness for us to be part of the healthcare solution in South Africa, and to make sure that we really can say at the end of this pandemic that South Africa really did do, as Nelson Mandela said, that we are the Rainbow Nation and we can actually be there for our patients. And the sanctity of life is really what we are all about. I trust that these few thoughts that I've shared with you will fall on really fertile ground, and that people will take the ideas that we've shared forward, so that this is not just talk, but that we can really implement what we've discussed. And I hope that this would really serve as a starting point for us to do that more effectively. Thank you very much.
Thank you, Audrey. Much appreciated. Very concise, very clear. The audience we have mostly there'll be a number of GPs in this audience, and each one of you has mentioned, all three of you this far have managed to mention the exact spot of relevance for GPs. And I'm hoping that they'll be interactive when we come to the question and answers session. Also, then what comes through is that we may need to engage your help in terms of strategy in engaging government. I think, again, when we have conversations later, we'll speak to that. Very key, and I think Prof. Hera spoke to this right at the beginning, very key to everything that has to be done in responding to an epidemic is quality of leadership. Absolutely. And I want to frankly say that we've been very much tested, but we're having this so that we can see how we build on it. Then let me welcome Stacy. Thank you very much, Audrey. Let me welcome Stacy. Stacy is also a physician and neurologist. She's in the Eastern Cape, so hopefully she'll give everybody a bit of a bite on real-time experiences as she presents her own. So welcome, Stacy. Please, you may take the floor. Take to the floor.
Thank you, Dr. Mlisana.
Thanks.
Okay, can everybody see my screen?
Yes, thank you, Stace.
Okay. So just thank you for this opportunity. I am a specialist neurologist by qualification, but I would like to think of myself as more a health systems manager, transformational and collaborative leader. And I just wanted to share just a few thoughts specifically on that with regards to integration of care, relationship building, etc. Okay, so these are just my disclosures. Just to give a quick overview, so the first few slides, I'm just going to do a bit of a corona update and some of the challenges that we're facing. I'm then going to look at sort of conventional clinical care systems and definitions thereof, and how that relates to the integration of care systems, and specifically using the stroke care example that we established here at Freer Hospital in East London, and then further going to a bit more detail of a transdisciplinary care and how such a model as a way forward could look like, or should look like at community level. So we've all seen these slides. I took this off the NICD website this morning with the pandemic just spiraling out of control, with sort of a split between public and private sector. And initially, I think across most provinces, we really saw an onslaught of cases presenting within the private sector, and subsequently sort of spilling over into the public sector. As of today, we were standing on 350,000 cases, with roughly close to 15,000 new cases recorded in the last 24 hours. If we look at the distribution of those cases by province, the Eastern Cape is right up there with 60,000 plus cases, with Gauteng now leading the way with 128,000 in the Western Cape, close second. So essentially, these are the challenges that we've been marred by. Initially, right at the beginning of the pandemic, many hospitals would close. Initially, we saw the closure of the private sector hospitals within KZN, and that followed numerous other hospitals, and specifically within the Eastern Cape, challenges that we've been experiencing in Port Elizabeth at Livingston Hospital, and here in my own region at Cecilia Makiwane Hospital. And there's many examples of these across the province and country. This obviously placed even more challenges on the ability to provide services, with wards being closed down, nursing staff not just falling ill, or healthcare workers not just falling ill, but in certain areas, healthcare workers not even, presenting for duty. So it really posed challenges on an already stretched stretched healthcare system. Although we saw those challenges, we started seeing examples, however, of integration of care, and how across the board already we started thinking of different ways of doing things. I've been following this example with a group of Durban doctors who, by their own accord, both public sector and private sector doctors, going into the communities and actually offering home-based care as a pre-hospital, within the pre-hospital setting, but then also following up those patients that they have discharged from hospital. So already, whether or not they knew it, they were already entering into this concept of integrated care. As Dr. Human had also pointed out earlier, around about a month ago, in our own region, we had made a call to our South African military to try and assist in the provision of care. And again, for me, that is a big untapped resource that potentially, could be expanded. But again, this idea that we cannot do this alone, we need collaboration, and we need to start taking each other's hands across this public-private so-called divide in working together, not just doctors, but across all the spheres of healthcare professionals, allied health, emergency medical services, all providing a platform of integrated care. So this then brings me to the essential differences if we look at team or health and healthcare models of care. And I think it's important for us to understand these differences, as it plays an integral part of the formation of these service level agreements, number one. But number two, more so in the context of severely constrained systems, and where a specific team might actually not have all the relevant team players together within that model. So if we just look at disciplinary, that would mean there's many team members from the same discipline providing care. I think that is the conventional specific disciplinary department going in and providing a specific care to their patients. If we look at multidisciplinary, here we start engaging this concept of different disciplines working together to provide a service. But as clearly depicted by the picture, these different disciplines hardly ever integrate. They work in silos. There might be a team leader, but essentially no real integration working in silos. If we look at interdisciplinary care, now we start getting closer to this model of integration, working together for the same good. Again, it's many team members from more than one discipline, somewhat still working independently, but at some point, some integration towards a common goal is starting to develop. If we look at examples of an integrated care pathway, this is sort of just the stroke care pathway that we had developed at Freer Hospital in East London. And literally, if we look at sort of the care pathway around stroke care, really gives us a good example of how different disciplines can integrate for the common goal. Here, for instance, I'm just showing pictures depicting the integrated care pathway for hyperacute services, where from the pre-hospital era, we need the emergency medical services to rapidly pick up the patient, screen the appropriate patients, then bring the patient to the hospital where there's a quick triage system involving relevant staff as well as documentation, as well as rapid recognition that this is an acute stroke, to rapid movement to your CT unit, for instance, and the availability of the thrombolytic agent. Again, multidisciplines, multi-stakeholders working together for the common goal, in this case, providing safe and efficient and effective hyperacute services. So that has translated in a number of patients being thrombolized with reduction in door-to-needle times and improvement of care. And this was just earlier this year, just to show, even using mobile technology, how rapidly that could be integrated within such a care model. This is further the example of the interdisciplinary team care, where again, multiple disciplines, allied health professionals working together around the common goal of reducing stroke morbidity and stroke mortality within a hospital setting. Just giving an example of how such an interdisciplinary team care approach would look like. So when we take this a step further into transdisciplinary care, I think what is important to note here, and this is essentially where we find ourselves within the COVID response, because very quickly with this rapid onslaught of patient numbers, not only, for instance, did we realize that we don't have enough generalists or physicians to look after these patients, and very rapidly we had to start looking outside of the normal physician looking after patients. And this is where this concept of transdisciplinary care comes in. It is where the relevant team members are willing to upskill and train themselves, with oversight from typically a physician, to provide care for patients. So again, same goal, same outcome, but now instead of staying within their irrespective discipline domains, they are willing to learn from their colleagues, pick up a new skill set, and then provide care with relevant oversight. Again, this whole concept of trusting one another, being able to be flexible, to learn a new skill set, being trained, and then being sort of with an oversight of the senior clinician. And I know a lot of this model has been implemented across many hospitals within our COVID response. So in doing some research, I found this diagram, which was published by King et al. In 2009, and looking at early childhood development and early childhood care. And the concept of sharing roles, the concept of working together for the common good, where an individual begins to utilize strategies and techniques from other disciplines, allowing to be upskilled and trained in that regard, in a sense to be an extension of the so-called physician in caring for these patients. Role expansion takes place, so team members pool ideas, exchange information, learn from one another, providing expertise into the care model. There's also role enrichment, so there's development of general awareness and understanding of different disciplines, beyond the scope of just the example at hand, i.e. in this case, early childhood development, or applicable in our setting at the moment with COVID care. So it is defined as sharing roles across the disciplinary boundaries, and it's hinged upon communication, interaction, and cooperation amongst these team members, being maximized or being incorporated for maximized outcome. The disciplinary team members, they commit to work together, implementing care protocols for the common good. And if we look at outcomes or the benefits of this, is that it's efficient, time efficient, energy efficient, cost effective. It's a cost effective strategy. And again, there's the sharing of knowledge, the sharing of skill in an area and domain where we might be strapped and we don't have enough of physicians, for instance, in managing COVID patients. So this was already, if we look again at the stroke care model, sort of the approach that we have started undertaking, where in the absence of speech therapists, here we see the speech therapist upskilling and training nursing staff to be as good at doing a safe and effective swallow assessment as themselves, as well as being trained in appropriate bed mobilization of the stroke patient by the physician. So again, in the absence of having each discipline represented within the team, transferring of skills and knowledge would be able to bridge the gap where those relevant team members or disciplines are not available. Again, a lot of what we're seeing within the current COVID sort of response and care teams. So this is just up to date what we've been doing at Freya Hospital. And this is just some examples of how we've re-envisioned and restructured our wards, how we've made use of this integration of care, where our physios have been upskilling and training our nursing staff with regards to proning of patients, being supervised by them, but allowing nursing staff to gain the skill to perform this. Again, wherever it's needed, we've been able to just leverage skill and expertise from one another. This is also an example where with not having enough high care or ICU beds, nursing staff have been upskilled and trained to operate, for instance, OptiFlow, high flow oxygen sort of devices within a ward setting, in the absence of, for instance, high ICU beds or ICU or high care trained nursing staff. And if we're needed, doctors themselves took a mop and a bucket of water and were wiping down beds to try and facilitate the rapid move of patients through the ED. But again, this concept of upskilling, sharing skills, so that we could leverage more healthcare practitioners in the absence of having enough physicians. Within this hospital, for instance, we only have 5 consultants and 8 medical officers, and that is the sum total of the internal medicine department. So we really had to rely heavily on non-physicians, orthopedic surgeons, our surgical colleagues, urology, ped surgery, everybody coming on board and forming this transdisciplinary team, being upskilled and trained around appropriate protocols with relevant oversight of the senior medical colleagues. I hope this plays. This is just an opening of a ward, and just to show how an integrated care approach looks like. I hope it plays. So just to show an example of how we were all sharing in this integrated care approach. So then looking at how a model like this could look like at community level, and there's been quite a few comments in the chat received around this already, in how at a ward-based level, the general practitioner being supported or overseeing a transdisciplinary care team could already be of massive value, whether it is in the pre-hospital phase, being able to up-refer to the relevant hospital, but likewise, once the patient has been discharged, to be then stepped down back to the general practitioner, which would also be able to integrate and communicate with isolation units. So for instance, an example like this would be where the general practitioner forms the sort of the integral part of the team, just as the overseer, but would be able to leverage, for instance, a community health worker or a home-based carer to facilitate contact tracing, conveying of results, education of patients within the community. At the same time, there would be integration or could be integration within the local community healthcare clinic for access of laboratory results and services, radiology services, as well as pharmacy, again, from both, and that might be your pharmacy at your community health clinic or your private pharmacy, leveraging all those services. I see such a model being integrated where the district has oversight and facilitating referral pathways as well as clinical governance, and then your professional nurse and your allied health professionals playing a role in then the monitoring of these patients and your POIs. Equally so, general practitioner together with his team have oversight and have a look or care for patients within the isolation units as well, where if a patient falls sick, there's up referral quickly to the appropriate level of care, whether within the community or you sort of at hospital level. I mean, all of the above hinges on service level agreements, the will to integrate care, and as well as communication with effective communication strategies. Just as an example of how such a transdisciplinary model of care can exist at a community level. So, I mean, the way forward, and a lot of the colleagues have already alluded to this as well as the speakers before, I honestly do believe that a transdisciplinary care model is possible across a public-private platform, as we need to leverage scarce skills amidst limited resources. There's no way that we're going to be able to safely and effectively care for our patients without taking hands across the public-private sort of divide. I do, however, agree that there's an urgent need of integration of these care practices, and to me, it makes sense that it's being led by the clinicians at the forefront, clinical leadership, and where within these different wards, that is the model of care where we take hands and we forge forward. But up until now, the challenge has been that we need the political will and drive from the provincial and the district departments of health to forge forward and integrate these services. Maybe in other provinces, a lot of progress have been made, but we in the Eastern Cape are still battling severely with this type of integration. And yeah, we definitely need to move forward on this rapidly going forward in this transdisciplinary care, building trust, uniting across these divides so that we can actually be more efficient and effective in providing care to our patients. Thank you.
Thank you very much, Stace. Thank you very much for your input. There's a particular slide. May you bring in that, may you just before you exit, just bring back that slide on transdisciplinary, the one that's got a circle in the middle. I'd like it to just remain fresh in our minds. That slide there, yes. You just come out of it, no? No, the one with the blue circle at the center, the very first one you showed just now. That one, yes. Thank you. Just to bring into the context now of the epidemic, if we can keep that in mind. Thank you very much then, Stacey. I think now I'll open the time up for questions. Some questions have been flowing around, have been thrown at the panelists. And perhaps then I would just, for context, just make one guiding element and say, perhaps, would we be in agreement that, firstly, just noting that we've invited two guest panelists who are coming from outside the province, and one of them has got experience in a province other than her own province, that's Dr. Adri Kok. And both of them have brought insights from outside the province. And then you, Stacey, and Prof. Hera are locals who are in the front line in the Eastern Cape. And so therefore I want to invite that in the 30 minutes that we have got, more than getting lost in the clinical aspects of the COVID-19 infection, coronavirus infection, rather that we focus on health systems and collaboration and integration. So if we can focus our questions on there, because when we are done, we want to be left with tools in our hands, and especially with our GP audience that is here and those who may be clinical managers at district hospitals, want to come out with a clear sense of what we might do once the presentation is over in terms of consolidating our thoughts. And I also think that Adri's presentation, I've seen that some people have been asking for it. We want all the presentations, but that one in particular will help them create a model that they want to engage government on. Now you, Stacey, and myself are involved in the provincial executive of SAMA here. And we've got experiences that I hope, Stacey, because I am moderating, you rather share as much as you can from our experiences in monitoring the provinces and the different regions' response to the pandemic, so that those who are outside the province can have an inside view from what we share. So there are two things I'd like the questions to revolve around. Firstly, to steal from Mark's statement about the dashboard, a real-time dashboard of experiences in terms of the responsiveness to the responses to the epidemic would be helpful between yourself and Prof. Hera, and now and then I'll comment because I'm well disposed to it as well. Then the second question that I'd like us to engage around is a sense of what is it that clinicians in the Eastern Cape, in our region, would like to tap from the wisdom of those who are outside the region. And so while we paint a picture from them, for them, but also let's tap on their wisdom in terms of what we need. And so therefore, I'm opening up the time now for questions. Please, you may come through, put on your mic, and perhaps let us see your face as you present your question, and also just say which of the panelists you'd like to direct it to, and I'll facilitate. Thanks.
Could I just, while the guys are thinking, one of the things that worked very well, I've found just in my immediate area, was to send out to our, and I mean I'm in Alberton, which is sort of south of Joburg, but in our environment in the Vaal Triangle, for example, we had over 400 general practitioners, and to send out just some education as to what to monitor patients for, how to protect their practices, what they could do, you know, to prevent people from worsening, for example. Would that not be something that one could start on your side, doing it from the hub, can I call it, of the hospital? Yeah. And then, you know, the only thing is to get hold of people. I think, to me, that is really what is going to be, I think, effective. And then, so that you know that the person that then comes to the hospital is really in dire straits. And I mean, and there are people, there's about 5% that really deteriorate. With your best efforts, you're not going to prevent them from coming to the hospital.
Just to comment on that, so I've been fortunate also in working both in the public and the private sector, and which obviously then lends itself to getting to know your colleagues on the ground, and that is definitely something that I do know colleagues in the private sector have been doing in a sense of engaging the general practitioners. It's whether or not it had been done with everybody, I think is the big question, and something that we definitely need to work on, because I do sense that the general practitioners, some of them, or a big group of them, do feel somewhat isolated, don't know what's happening in the hospital. I love the one comment from one of our colleagues in the Eastern Cape. We are fortunate in that we have an in-house developed data collection system, which is busy being rolled out across the province to the big hospitals. But again, it's not something that the healthcare practitioners have access to. So that might be also something that one could leverage, providing obviously that there's minute-to-minute, up-to-date information available, which is then highly dependent on those in the hospital to input, and to then be able to facilitate that communication between not just the GPs knowing what's happening in the hospitals, but I think we definitely need way more integration between the public and the private hospital sectors in our province. In East London, for instance, we only have one private healthcare provider, PE. I think there's 2 or 3, and sort of in the Mthatha region, there's only one. So I cannot see why such an integration, would not be possible. And I do think on the ground, there's more than enough communication happening between the public and the private sector to facilitate such arrangements. I think where we then get stuck is the red tape around these communications or integrations, and I think that for me is the biggest. How do we get around the red tape? That's often where we get everything going on the ground. We talk, we want to share beds. We like one example I didn't even mention is how our provincial emergency medical services are talking to the private emergency medical services just in Buffalo City, and how they try and how do I say leverage, okay, how many beds are available, where are you guys standing, where is it full, and then they now starting to speak to us. So like I said, on the ground level, it's not a problem. We're phoning each other, we're asking, we're transferring, but it's then beyond that where the red tape is the limiting factor. So how do we get around? How do we get around that?
I think also that if you look at the just in Port Elizabeth, for example, some of my EXCO members work in some of those private hospitals. They've been overrun again as well. But again, it's really to try and de-stress that situation, to be able to ensure that they communicate again their best efforts. But I think the most important thing is talking and letting people know where you are. From the Hospital Association, for sure, there is a dashboard available. So that's updated every 3 hours. So maybe what we could do is in the province then make sure that can I call it the leaders in the other provincial hospitals then have access to that website or whatever it is, to be able to see what is available and where can one go, and then that also to have the EMS as part of that system, because I think if one could do that, maybe that coordination could work better. I know one of the hospitals is a Netcare, in PE, and the other one I think is Life or Mediclinic. Life, I think it's Life, isn't it?
Yeah.
So we'll take it to them as well and see what better way one can find to communicate that.
Thank you very much, Adri.
Hello?
May I then, because I'm watching
Hello?
the time, may
Hello?
I try to, Prof,
Yes.
Prof, I can hear you. We just don't see you because you are in darkness there. But
Yeah,
I was
yeah,
just making a request. I'm just making a request that you guys allow me to moderate the conversation so that nobody loses opportunity to speak, because we've got very little time left. And Prof Hera, the way I'm going to ask you to approach it then is firstly throw in any more wisdom you want to throw in, but also keep in mind questions that were fielded to you, which you may want to address here now while you speak. And I'm going to ask the other three panelists to do the same, that they respond to questions here live, taking turns. And after you, I'm going to ask Mark to come through. So please do, Prof.
Thank you very much. First of all, there was an issue of psychology. When I'm talking about, in terms of psychology, remember on my last slide, I said pre-lockdown, post and lockdown, and post-lockdown. So under post-lockdown, actually, I did put something, the so-called counseling. Under this counseling, I cannot unpack all here because the time that we are having is just very brief. But the psychology part, the behavioral change, social environment, and also motivation to the communities all goes on that word counseling. So maybe I can say social behavioral change or social behavioral psychological change, whatever we can be able to mention. But psychology component goes in there. The third issue, the second question was, why are we still having such many cases while we have got all the knowledge that we have? The issue here is, initially we were not able to address the problems up to the community level. We addressed the problem mostly knowing that most of the people had an assumption that these problems actually in the cities, in the mega cities, in the cities, and not to the rural communities. This is where actually we did forget to give proper information to the communities. That's number one. Number two, when we were actually imposing the lockdown, people were going to the communities without knowing exactly what COVID-19 is. And what message were they going to bring to the communities that they were going to face, to their parents, let's say students, to their parents, workers from the cities, to the communities where they're going to stay. Well, they didn't know what is COVID-19. So it was like creating a fear, panic, and phobia to them because they don't know why they've gone there. But now, actually, we are happy that the community is now aware on what COVID-19 is. And now they're coming back. It is like a pyramid which was going down, up, down, but now it is down, up in terms of emergency preparedness. So this actually is going to help us quite a lot. And remember, these GPs are all in the communities. And if we are to enforce and create a proper relationship between ourselves and those GPs, it should have created a very good synergy in the whole environment of emergency that we are dealing with now. Now we are also requesting for reinforcement, or also including these initiative clinics, health centers, to be involved in the fight against this COVID. We have no proper referral system. We need them to be involved. Once they are there in the rural areas, the GPs are the ones who will detect them. Once they've detected them, they will refer them to the proper channels. The other issue is we have a problem of these ambulances. How are you going to transport them? So the whole package actually involves not only at the hospitals where we have concentrated more, but also there at the community. Once those ones knows what to do, then it will be easy for us actually to support and assist the GPs who are with us. And our private hospitals, our international hospitals, the NGOs will be able to play a very big role in terms of all this control of this COVID. And finally, what are we going to do with the coordination? Coordination, communication, monitoring and evaluation should be very active while we are dealing with this COVID. Thank you very much.
Thank you very much, Prof. Mark, may I kindly ask you to just come back and especially perhaps address the issue on the dashboard and any other questions that may have come through which you'd like to address, please.
Thank you very much, Zalile. I wish I could honestly answer the questions because there are more questions without answers at the moment. I have to agree with what Prof's saying. I do think across the board we have a hospice-centric approach in South Africa, and bringing in GPs and bringing in the community is going to become imperative. We've heard our own president say this is the time to bring in NHI, and that brings shudders up the spines of many people, because I think most of us realize that you don't want to be implementing NHI on a totally smashed system. You need to fix the system and then bring in NHI. And I don't think anyone's in disagreement that universal healthcare access is an imperative, but we need to get it right, not implement it on the horribly damaged system that we have at the moment. My personal experience in other healthcare systems is that the building block is the GP, and certainly they're the gatekeeper and the fund holder in most ways, and that seems to be a system that works very, very well. They look after their downstream, which is the community and the ward-based teams and so on like that, and they refer upwards and they control and balance access to secondary and tertiary care, and that makes a lot of sense. And I'm not quite sure why we haven't been looking at implementing a model like that a lot earlier. Of course, we won't fix all of the country's problems in the next few months, so we have to pick our battles wisely at the moment. One thing that puzzles me and a lot of colleagues is the restricted access to information at the moment. This is all going to come out in the wash at some stage, and the way things are going at the moment, some of our provincial healthcare departments are going to get crucified in the post-mortem of COVID for failing on so many levels. And restricting information really is not going to help that in any way. It's just going to make it worse. At least if we have information, we can make intelligent contributions or suggestions or choices across the board. And I'm not saying that you need to make a public dashboard, because we really don't need to be terrifying the general public right now. But I can't conceive of why, with the IT platforms that we have available to us, it's so easy. My 13-year-old can create a Google spreadsheet that does this kind of thing. So I really can't conceive of why we don't have a system where you can log in, where any doctor can log in. And even if you say we'll restrict access to your province or even just your district, and you can find out what's happening where and where the beds are available. I'm hearing all the time from GP colleagues that I've got a sick patient, but I've phoned 7 hospitals now and I don't know where to send this patient. And that's across the board, whether the patient's funded or not funded. And actually it shouldn't matter in a time like this, whether there's funding or not funding. I've got a sick patient. This patient needs an ICU bed. Please get me an ICU bed. There should be some kind of a control, a bed bureau, to use a Western Cape term, because theirs seems to be the most functional model at the moment. Where you can phone and say, I've got a patient who is drastically ill and they need ICU treatment now, in the next few hours. Otherwise, they are going to die. But that system doesn't exist. And I don't believe that we don't have the tools to to implement it. I think that most of it's there. It's just opening the doors that have been closed just traditionally for reasons of I'll do what I do and you do what you do. But now we're not in that space anymore. So let's open all of those doors. So that would be my plea. I wish I had some answers to the questions that are being asked.
Thank you very much, Mark. No, that is definitely helpful. If I may, and then after you, I'm going to call on Stacey. If I may, just the first one, you made the point already, but I just want to emphasize it yet again, which is the fact that this epidemic provides opportunity for all of us to prove in collaboration what we would want to do in providing universal health coverage. Not so much the financing model, but how the systems work on the ground. And this is a great opportunity. I think somebody has emphasized this, that it must start from the bottom up. And I want to just say that I want to encourage our GP colleagues in my perinatal outreach throughout the 2 districts here. Relationships were built and we're at a stage in terms of perinatal care. And I'm reminded by what you mentioned now. There's a Vula app, which Mark, forget the surname now, Fata, is working on. And we're developing something that is going to give us a real time. We started on this when I was in Gauteng, and I'm trying to transport it to here. But here is the bottleneck. Initially, when we started, it was government that's saying they don't want anything independent from their IT systems.
Yeah.
That becomes a sort of a block to any initiative that clinicians try to do from the bottom. But I want to encourage GPs to work together so that we can build it from the bottom. When this is done, I will be getting back to them. We are looking at a technological dashboard that is going to be quickly working through, and the Vula app guys are actually looking at it for us. So thank you very much for that. But the second point is that the districts have to lead, which then reminds me that I must just apologize and send an apology on behalf of our district manager, whose ear is very close to the ground. And again, it's born from doing the perinatal outreach from the regional hospital throughout here. We've got clinical managers now, some of whom may be attending this webinar, who are very close to the conversations now of how do we integrate GPs into supporting what we're trying to do. Because the model that everybody was stuck at was the, thank you, Adri, again, for the service level agreement that you have crafted. They were stuck at the contractual agreements with GPs, which were just for sessions, and again, hospice-centric, which are just on hospital services. But now we're turning that around into something more than just a contract, but into something that is going to take the model of capitation, because it's going to be village-based, which means it's not going to be hospital-based. It's complete different in terms of the epidemic from addressing hospital-centric treatment. So we're looking at that and want to take it up. And Professor Hera has been very helpful from the School of Public Health in facilitating that. So thank you very much. You are reinforcing some of the things that we are working on already. Thanks, Mark. You may not have answered, but you've alluded to some of the things that are very, very important and which we are trying to deal with here. And we'll be calling on you guys in between, because we know you now and then when we need some direction. But thank you very much. And then Stacey, I think I heard you wanting to come through. May you please?
No, it was, I think it was Prof. Kok. I think, yeah.
Okay.
I'll
you may come
be very
through,
quick. It's just one of the comments from one of the chats is about the diabetic patients and how our diabetic patients have really, this is probably one of the situations that has highlighted our poor diabetic care. Patients that are presenting with very, very severe COVID because of the diabetes that drives the whole inflammatory process. And, you know, the other important thing is that we've started about 4 years ago now, we're now 4th year in my area, where I as physician have a group of general practitioners, and we coordinate care with the help of nursing sisters in the community. And you simply stop people having to come to hospital. And you know, if you can duplicate that system and just really spread that kind of way of doing it, there aren't enough specialists, there aren't enough general practitioners, there aren't enough nurses, but we're not working efficiently with what we have. And I think that can really, really improve. If you see what Stacey has achieved in her area, she's been a phenomenal leader, and she made a difference. And that's what we need to do. We need to have people that have that same drive and have the same sort of a vision of what can be done, not to sit in their own little corner where they only see their own problems. You know, if we could just people get to see the bigger picture and really to understand that they could make a huge difference where they are if they just use the facility and just develop where they are what they can do. You don't have to solve the whole of South Africa. You change your area. You know what your challenges are. Make a difference where you are. You know, we just have to put pressure on the provincial sector and the government sector that have to help us to run these programs. They're really good programs, and they're gonna save lives, not just for this pandemic, but even as we go forward.
Thank you very much, Adri. We are left with 4 minutes now. So I'll make that your last bite, Adri, unless there's just one more thing you want to say in closing and thanking everybody. Thank you. All right. Then, Mark, may I ask you, we've just got 4 minutes left, if you've got one last thing to say.
Put me on the spot there.
No, it's fine. We just so 1 minute each and we're done. If there's nothing, Mark, that's fine. That's all right.
I have so many things to say. I hope there's someone on this call who is integral to any provincial or district Department of Health. Please know, we have been knocking on your door ceaselessly for 4 months. There are so many ways to integrate. One of the people on the chat has alluded to the fact that they would gladly offer their time if they were just able to slot in. So be innovative, create a Google spreadsheet and say, we've got this slot here available at this hospital. Please sign up. Or you know, there are so many different little ways we can contribute. Please do not ignore the private sector, because it's got capacity at the moment. We created this capacity to make space for all the patients that are going to come. Thanks.
Thank you, Mark. So you're offering, can I give your number to these guys? But I get you. I'll come back to you, Mark. I heard you. Okay, thank you very much. Stacey, do you have your last word in 30 seconds?
I just wanted to say that it really starts with a bottoms-up approach. You know, if we're going to sit and wait for, you know, the powers that be to get with it and get on it, we're really going to be facing massive ethical issues. So I just think, like Dr. Cocker said, every little hospital, you know, each doctor, leaders in their own right, let's sort of just work within our communities and just literally from the bottoms up. That's the only way we're going to be able to get this massive, big Department of Health moving forward. So we're going to have to just do it from the bottom up.
Thank you very much.
And data, important.
May I then commit you and I through SAMA to get closer to the GPs, because they work as individuals and they do not have a forum other than what we can provide in terms of putting their minds together. I'm very much engaged with district this side, but I think we should speak to all the districts throughout. So I think let's take this back to Sama, you and I. Professor Harry, your last input.
I would like people to follow what actually OR Tambo is established currently, which is the war rooms. And those war rooms are actually explicitly integrating all parties in terms of this fight against COVID. So let us all join hands and make sure that we defeat this enemy which is within us. We cannot fight ourselves as the healthcare workers, but all the community should be involved. Thank you.
Thank you very much, Professor Hera. Stacey, I think we should adopt Professor Hera and give him an honorary membership at SAMA, because he and I work together with districts and the GPs. He'll bring in a wealth of wisdom into that. We won't overload you, Prof, but I'm just giving you access so that your wisdom can come through. Then the second and the last point I'd like to make is that when we talk about war and when we talk about command structures in leadership, there is a danger there, and I've observed it here in our region. There's a danger in giving command authority to people who then undermine clinical, professional, and all other intelligent advice that they could benefit from. So you and I, Prof, should really elevate the leadership of clinicians, because the structuring of leadership in terms of command is dangerous, because if people are given command authority, then undermine science, it doesn't help. You will remember that when this all started, there was no focus at all at community level interventions. And that's why in this particular region we're in a problem. The focus was on countrywide, of course, was on critical care. And yet we needed to stem the tide right at the bottom. And that's because typically, as you say, when there was lockdown, the command was, thou shalt stay in your home. But there was no clarity about how and why. So therefore, the leadership of clinicians has got to be brought together to the center, so that then the bottlenecks that come from command leadership, which may be ignorant of clinical facts, then may be stemmed. Thank you very much, colleagues. I hope that the audience who are not able to, whose faces were not able to see, but we got your questions, this was of benefit. We in our region look up to everybody else in the country to help us where we can learn from you. So please be available to us, and thank you, Mark. Thank you very much to the South African Medical Research Council, and thank you to yourself, Patrick, for staying with us. This has been very, very helpful. Thank you, colleagues. Let's march on as clinicians and provide leadership. Thank you. Bye.
Thank you.
Thank you very much, everyone.
Thank
Thanks,
you.
Olivia.
Bye-bye.
Thanks,
Bye.
Patrick. Bye-bye.
Although you cannot see me, but I can see you all.
Thank you, bro.
I'm in darkness. Bye-bye.